lymphocytic lymphoma or chronic lymphocytic leukemia, right? Small lymphocytic lymphoma or chronic lymphocytic leukemia. Actually, previously they were considered two different diseases, but presently we think that is one and the same thing. Only one difference is there, as I mentioned previously. The only difference between SLL and CLL is that in SLL there is cohesive mass of the neoplastic lymphocytes, but cells in SLL, cells don't spill in circulation in big number. But in chronic lymphocytic leukemia, the cells are spilling into general circulation in very high number and WBC count is very high. This is one thing. Secondly, if these are small lymphocytes, what do you think? They will be aggressive or less aggressive? They should be less aggressive. If they are, because large lymphocytes are more aggressive, they are more neoplastic. So because these are some small lymphocyte, right, they are less aggressive, so this disease will be acute or chronic and gradual. These are small lymphocytes. They are less aggressive, they are less transformed, they are less malignant. So basically, this is indolent disease. And it is more common in elderly people, right? And this constitutes up to 30% of leukemias in the West. 30% of the leukemias in the West. The real problem in this condition is that these are the B cells, and if these are the B cells, small B cells, right? What do you think, which markers should be there? Please. 19. Yes, very good. CD10, 19, 20, even 21. Now these are B cell markers, right? These are B cell markers. But there is one very unusual thing about it. These neoplastic B cells do have one T cell marker. I mean, very unusual thing, very unexpected thing, but it is true that in SLL or CLL, even though they are small B lymphocytes and they have all the B cell markers, including the surface immunoglobulins, right? But unexpectedly, they do have one T cell marker, and that is CD5. There is one more non-Hodgkin's lymphoma which also is basically B cell derived but having CD5 positive feature. Anyone knows? Again, point which I am stressing, it has B cell markers, but unexpectedly it does have one T cell marker. There is one more non-Hodgkin lymphoma which is also B cell tumor but also has CD5 positive feature. Who can tell me? Mantle. Very good. She is good at finding the things from notes. Mantle. Now the question, mantle cell lymphoma. Now question is that what is the common thing in this condition and mantle cell, and what is the difference? Now this is very important. Let's compare and contrast. We go to the very basic diagram. You remember there was bone marrow house and there was circulation, is that right? And then there was, yes please, lymph node, germinal follicle, and there was mantle and marginal zone. Okay. Now, here was lymphoblast. You remember that? Here were lymphocytes which were naive lymphocytes. And then there were mantle cell here. Right? Now, basically, SLL or CLL, that is derived out of these cells. Naive B cells. Is that right? Naive B cells. And here is the next stage of that. What is that? Yes, mantle. And then of course, you know the remaining stages rapidly, you tell me. Follicular blast, then centroblast, and then centrocyte. Is that right? And then marginal lymphocyte. Okay. What you have to say it, that SLL or CLL that is originating from here, that lymphoblast have been differentiated into naive B lymphocyte, but they fail to differentiate further. If they fail to differentiate it further, do you think SLL or CLL will have hypermutations? Somatic hypermutations? No. Look, SLL or CLL is at this stage and mantle cell lymphoma is at this stage. But somatic hypermutation occur in germinal center when they are stimulated by antigen. So do you think these tumor cells, either SLL, CLL or mantle lymphoma, are they stimulated by antigen? No. And have they gone under somatic hypermutation? No. So these are the common features in SLL, CLL and mantle cell lymphoma, that they are all positive B cell markers, plus unusually, unexpectedly they are positive for CD5, which is actually T cell marker, plus they don't have hypermutations which were supposed to be here, and plus they have never been stimulated by antigen. Right. Now, because this tumor is starting in the bone marrow, because if it starts at this stage, it will become leukemia and spill over. Or if it is here and settle into a lymph node and then it is lymphoma. Is that right? Now, it almost always, this type of lymphoma or leukemia involves the bone marrow. So what clinical feature will come with involvement of bone marrow? Rapidly. Pancytopenia. Right? That will eventually lead to what thing? Anemias? Yes. Leukopenia or infections, and thrombocytopenia or bleeding tendency. Another thing which is very important. Do you think immune system will be working well in SLL, CLL? Of course not. All Hodgkin's or non-Hodgkin's lymphoma immune system is disturbed. We have already discussed previously. So what will be the problem? Immune system is suppressed. Hypogammaglobulinemia. Because actually, not only these tumor cells are dysfunctional, they suppress the immune response against other antigen by the healthy B cells. So healthy B cells are unable to convert properly into plasma cells and make immunoglobulins. So these patients will have hypogammaglobulinemia. Hypogammaglobulinemia, right? And another dysfunction I told you, in which autoreactive B and T cells are released, and that may end up into what type of problems? Autoimmune diseases. So in this condition, some patients do develop autoimmune hemolytic anemia. When we go into morphology, right? When you go to morphology, what really happens that these cells, when they infiltrate the lymph nodes, again, these cells, SLL, CLL will infiltrate bone marrow. They will infiltrate the lymph node. They may even involve, what is this? Liver and even spleen, right? Because normally when these naive B cells come into circulation, normally they go to liver, spleen and lymph node. So these neoplastic cells also go to all those areas. So there is bone marrow dysfunction, plus there may be hepatosplenomegaly. Along with that, in these patients, there may be generalized lymphadenopathy. Any question up to this? Now we come to karyotypic changes. In karyotypic changes, yes, was there any translocation associated with this we discussed? No. We discussed translocations related with follicular, Burkitt and mantle. So with this tumor, SLL and CLL, there is no translocation. They are basically trisomies and deletions. There is trisomy 12. What is trisomy? Yeah, 12 number chromosomes. Rather than 2 copies, there are 3 copies. Or there may be deletions of 11 chromosome or 13. What does it mean? It means the chromosome number 12, there is some proto-oncogene. And if there is extra dose, cell will over-proliferate. Or chromosome number 11 or 13 have some tumor suppressor genes which have been deleted and cells are over-proliferating. Am I clear, my friend? Sure? Okay. Then we come to that when these cells will invade the lymph node, do you think they will make follicular pattern or they will make diffuse pattern? Remember, follicular patterns are made by these mature cells. Right? So if this is this cell or these cells, they will make diffuse pattern. Let me make a simple rule. SLL by CLL, right? That is making diffuse pattern. And very aggressive, very large B-cell lymphoma here also make large B-cell lymphoma, also make diffuse pattern. Is that right? This is also making diffuse pattern because it is not mature enough to make the follicle. And large B-cell lymphoma have lost the capability to make follicles. But other tumors which are there, follicular lymphoma comes out of this area. Or mantle zone lymphoma, they may be diffuse or they may be follicular, because if they are differentiating a little on this side, they will become follicular. If they are less differentiated, they will make a diffuse mass. Am I clear, Seth? There is no problem into this. So what we have talked about, that what is this tumor? SLL, CLL. This is making diffuse effacement of the lymph node structure, no nodular pattern when this involves a lymph node. And then later on we will talk about diffuse large B-cell lymphoma. Cells are so undifferentiated, they are unable to make follicular pattern. Right? In the same way, Burkitt lymphoma. Burkitt lymphoma is very aggressive, rapidly proliferating. It will make follicular or diffuse? Yes, it must make diffuse. To make follicular pattern, cells should be more mature and they should be relatively less slowly proliferating, rather simply accumulating as it happens in follicular lymphoma. Right? And now, last but not the least, very classical feature on the slide is, right, then when you take these cells on the slide and you make the slide of these cells, some of these tumor cells are very fragile. And because some of these cells are very, very fragile, so what happens? That they rupture when you make slides. Am I clear? And these cells, tumor cells, or neoplastic cells, or transformed cells which rupture, right, when you are making pathological slide of histopathology, right? Or from the blood-derived cells, these cells which rupture, they are given a special name. Anyone, what is that name? Very good. Cells. Right? Now, if someone asks, what are the clinical features of this condition? It's very simple. Initially, it will be asymptomatic. When it will start, it will be initially asymptomatic. Then, as tumor load will increase, right, cytokines will be produced. Then non-specific features of neoplasia or inflammation start, like weight loss, anorexia, easy fatigability, right? And eventually, as disease further advances, features of marrow failure will come and patient may develop infections or bleeding tendency. Then, if autoantibodies are found, patient may develop autoimmune hemolytic anemia and related features. And of course, more advanced stage, patient will develop hepatosplenomegaly with generalized lymphadenopathy. And you should not forget, if it is CLL, then there will be very heavy leukocytosis in the blood. Is that right? Because a lot of cells, leukemic cells, have jumped into circulation, right? Median survival is 4 to 6 years, and these tumor cells can progress to more aggressive tumors, right? And more aggressive tumors, number one is pro-lymphocytic leukemia. Pro-lymphocytic leukemia means these cells go more earlier stage from here to here. It means little more failure in differentiation. Pro-lymphocytic leukemia. Or they convert into, yes, DLBL. What is DLBL? Diffuse large B-cell lymphoma. Now, if CLL or SLL cells go to a lymph node, listen, the cell which enters the small cell, is that right? But within the specific lymph node, it convert into large B cells, right? And now this has transformed into diffuse large B-cell lymphoma within this specific lymph node. When such kind of finding is seen, it is given a special name. Again, listen. For example, I'm suffering with SLL or CLL, and disease is moving a little bit slowly. Then some of these lymphocytes or one of these lymphocytes enters into a lymph node, right? And there it transforms into more aggressive form, that is diffuse large B-cell